Hey everyone, welcome back to another episode of Forward Physio. I am very, very fortunate today to be sitting with Ebonie Rio. And if you have been living under a rock, Ebonie is a tendon researcher, a clinician who has worked in a ton of very, very, very cool settings, and just one of the go-to experts in tendon pain. Ebonie, would you mind telling us a little bit about yourself and your career as a researcher and a clinician so far?
Sure. First of all, thank you so much for the invitation. I'm thrilled to chat with you this morning. So, as you said, I'm a physio and a researcher, and I probably can't decide what I want to be when I grow up because I love both. But I think both make me better at the other one. So I still love being a physio. I still love working in a team and working with athletes and dancers and, just really helping people to achieve whatever their goal is, and that shared decision making and that motivation and, just everyone working towards the same thing. But it's also those clinical challenges that really drive my research questions. So it's the people that don't get better, or it's the really tricky in-season management, or how can we do this better, or if something did go well, why do we think it went well? Can we explain that? So I do have having a foot in each camp because I think it's really fun.
Yeah, the clinician researchers are someone that, are really, really important for our field. And I think you have such a great insight because on one hand, you have all of this clinical experience. And I think that is so helpful for forming really, really relevant research questions, because all the time there's research that comes out that maybe isn't as clinically relevant or doesn't explain things well for a clinical context. So I think it is a really interesting perspective.
I agree. But interesting, actually, just to pick up on that point, because I think it's a really good one, it also really hones your research. So one of the things I feel really passionately about is differential diagnosis, because it really changes your treatment direction. So that means I am so careful about my inclusion criteria, because I want to make sure if someone's reading one of my papers, they're really clear about whether or not they can or can't apply it to the person in front of them. So, all anterior knee pain is not patellar tendinopathy, for example. And in one of the studies in my PhD, I screened 228 athletes to get 29 with patellar tendinopathy. But I was
Wow.
more concerned about having a homogeneous group of people with a meaningful clinical outcome than some people got better, some people got worse, some people stayed the same, more research is needed, because I don't know about you, but that does my head in.
Yeah, I was reading a study shortly before this to help prepare, and it was, I'm sure we'll get into the study later on, but it was that systematic review that came out recently about how there's not good evidence whether people are improving from Achilles tendinopathy based off of improvements in the structure and the function of their tendon. And I was looking at the inclusion and exclusion criteria, and there was these two sentences where it said, mid-portion and insertional Achilles tendinopathy are two different clinical entities or something along those lines. And then the next line after that was, most studies did not determine whether it was mid-portion or insertional Achilles tendinopathy.
And most studies don't even determine if it's the sheath or the peritendon, which is a totally different clinical entity. So, yeah, that's something I feel like really passionately about. And, I think that's why I still spread myself between the Victorian Institute of Sport, which I love, and the Australian Ballet, which I love. And then I still hold my research position at La Trobe. So, because I would like to think there's some value in having a foot in both camps. But yeah.
Yeah, I saw your practical recently on Physio Network, and there was a lot of just differential diagnosis based stuff on it. And I think for anyone who isn't signed up or who hasn't seen it yet, I think it's a really, really good tool because
Oh,
there's so many
thanks.
things that could mask themselves as, Achilles tendinopathy, which we may or may not get into today, depending on how sort of into the weeds we get.
Depending on how many times I keep interrupting you.
Please interrupt me as much as you like. I'm sure people are listening for you and not for me today. Let's just start with a pretty simple question here that will help ground the rest of the conversation. So, what are the ways in which a tendon can cause a painful problem?
Nice. That's a really nice place to start, actually. So, if we think of tendon injury, we really are talking about four different clinical conditions. So, the first one that I'll define is tendinopathy, and we talk about it as being pain and dysfunction in the tendon. But what does that mean? It really means that the pain remains localized, that it's provoked with high tendon load. And high tendon load is anything that's fast. So it has to be fast and be, energy storage and release for it to be high tendon load. So that automatically means the converse of that is that slow and static load are not provocative for tendons. So if we consider tendons as a rate of loading condition, we can automatically say, well, we know which loads won't provoke them. So we don't have to rest people. We can just take away those provocative loads. So we're talking about tendinopathy and how it relates to, our spring type loads. Our second condition are conditions of the peritendon. So you might remember from university, you have these synovial layers that slide and glide over a tendon. So that's things like cycling, swimming, rowing. I don't care how hard someone pushes off the wall. Swimming is not high Achilles tendon load. It's not high tendon load in the lower limb at all. But what it is lots and lots of range of motion. But what we've got to be careful of is the person that says to us, oh, I run, but I don't get my Achilles pain until 5 kilometers into a run. Because what we've also got to do is incorporate the features of tendinopathy. And tendons warm up, but peritendons don't. So what's happening with the person that gets pain as they run is they fatigue. So they ground strike, and then as they fatigue, they go through greater ranges of motion and they overload the peritendon. So we talked about tendinopathy being focal pain. We talked about being related to high load, but we need that third feature that it warms up. That's a really important characteristic. And I've been caught out by a lot of these. So I want to share that as a little clinical gem. Your peritendons will get worse the longer you go because it's related to friction. So why do I care? Because someone with Achilles tendinopathy can do isometrics if you want. They should be doing isotonics. But I hope you can see that isotonic or a calf raise is the provocative load for the peritendon. So those people won't do well with an isometric or an isotonic. So it's critical that early stage we differentiate those two clinical conditions. Now, our third condition is conditions of the bursa. Usually it's related to the emphasis. So if we think of our retrocalcaneal bursa, it's part of the insertion of the Achilles and the calcaneus. But something like the superficial bursa or the calcaneal bursa sits outside, and it's provoked down on the heel by footwear. And so, again, we have to really listen to our patients and our athletes. And the person that says to you, I have posterior heel pain and I'm worse in shoes, it's likely to be friction or compression, as opposed to someone with insertional Achilles. They hate being in bare feet because they get into compression sooner and they prefer to be in shoes. So the devil's in the detail, but it's so important if we want to remove that provocative load to really be listening carefully to that detail. And our fourth condition is tendon rupture, and that's really tricky to prevent because people don't usually have pain until they rupture. So we tend to see them. We know that they're likely to have had pathology, but we don't see them until they present with that sort of acute clinical incident. So that's kind of a bit of a synopsis of, tendinopathy, peritendon bursa and rupture. And, as we continue to chat, I'll be purposefully repetitive, especially around tendon load, just to really burn it into your neurons.
Got it. Okay. So right at the end there, you mentioned that when it comes to a tendon that could rupture, that sometimes there may be sort of something wrong with the tendon beforehand, but the person may not be in pain. So what are the main differences between a tendon that may seem pathological versus a completely healthy tendon?
Okay, so the patellar tendon and the Achilles tendon are a little bit different in terms of the pathology that we see and how it develops. So the Achilles is a load over time change. So it's not that you get tendon changes just with age. It's just that as you age, you've had more opportunity to accumulate load. So Kevin Liebethal's master's work showed that in asymptomatic tendons, so these are people with no tendon pain, the people that had been running on average for 7 years or more had changes in their tendon. So they didn't have pain, but they had changes in their tendon. And so it's a little bit like scars on the skin. It looks different, but it's very functional. So we don't need to worry about these asymptomatic changes. We also see from Sean Docking's amazing work that our Achilles and patella tendon are capable of amazing adaptation. So something like an increase in AP diameter is adaptive. That's fantastic. And in terms of our patella tendon, we see that those changes actually develop during puberty. So as the patella tendon is trying to form a mature attachment, if someone's being really active in that period of time, particularly with jumping and landing and high patella tendon load activities, we can see these changes that might be reported as, hypoechoic areas or increase in AP diameter. Because that's when you're laying down your patella tendon, you're also capable then of that, incredible adaptation that we also see. So the clinical kind of inference, or there's a couple. Tendinopathy is a clinical condition, not an imaging diagnosis, because if we image your patella tendon, later in life, you might have had those changes since puberty, so they're actually not relevant.
It's to me always a sort of confusing thing. On one hand, there's these positive adaptations, like that increase in the AP diameter. On the other hand, I think we could get a tendon that looks pathological, but isn't necessarily painful. And I'm going to read to you something that you wrote. I think it was about 10 years ago. So
hopefully I still agree with it.
Well, I'm sure there's other people on this paper. Maybe you could blame them for writing this if you don't agree with it. Okay, so it says, many clinical features are consistent with tissue disruption. The pain is localized, persistent, and specifically associated with tendon loading, whereas others are not. Investigations do not always match symptoms, and painless tendons can be catastrophically degenerated. As such, the question, what causes a tendon to be painful, remains unanswered. And
I still don't know the answer.
I was going to ask you, 10 years later, are we any closer to answering this?
Yes and no. So on the one hand, I actually agree with what we wrote back then. The features of lower limb tendon pain, at least, don't spread regardless of, length of time of symptoms. So we can become more sensitive with that tendon, but we don't get, the spreading of pain that can be associated with persistent pain in other conditions. It's probably associated with, a type of ion channel, and that research is really, really tricky to do. At the end of the day, we still need to remember that pain remains an output, and that there's so many other contextual factors that will influence someone's pain experience. So I think the key point I would make out of that remains that we just still need to actually understand tendon load, because someone with patella tendinopathy can run pain-free. They can cycle. There's so many physical activities they can do because that isn't high tendon load. So I think we need to not rest people and really understand and make sure we're listening to them. So the example I gave right at the start around the peritendon, if we gave someone with Achilles peritendinitis the advice of, just be active and physical activity is good for you, they'll actually get worse, because we haven't listened to their provocative load, which is movement, and we haven't addressed it. So we can't treat people with these conditions the same. They actually still need to remember the bio in the biopsychosocial.
I do want to get into that management of the peritendon versus the tendon pain. But before we get into that, I want to ask, we mentioned that these catastrophically damaged tendons aren't always painful. Will we see maybe a functional deficit with a tendon that appears damaged or degenerated, even if it is painless?
Yeah, it's a great question. Susie Edwards has done some work in asymptomatic patella tendons, but that have pathology. So a patella tendon abnormality was what she called it in her research, and they were stiffer in their landings. So they definitely had a different strategy. So we do see a manifestation or a change in people's loading even that isn't associated with pain? So that is a fantastic question. I would, if I was going to change one thing about what I wrote 10 years ago, I'd get rid of the word catastrophic. That's so doom and gloom. What a terrible word to use for people. So I apologize, everyone. Remove catastrophic, because some of that language really promotes fear, and that's not something we
Yeah,
want to do.
that's a good point. Okay.
Sorry about that.
I always love two things. Number one, when we can be optimistic. Number two, when we can change our mind about things as well. So
You have
awesome.
to.
Yeah, of
Absolutely.
course. Definitely. So when it comes to muscle, we tend to think of like muscle growth as a positive adaptation. When it comes to the brain, we think of when we create new brain cells. That's a positive adaptation. What does a positive adaptation look like in a tendon, and how do we go about achieving that?
Oh, such great questions. So we talk about it broadly under the kind of umbrella of mechanical capacity, and so what that means is we're getting changes at a microscopic level to the biochemical environment and the way the tendon cells communicate and the way they're continuing to promote the health of the proteoglycans. So we don't want big aggrecan that binds a lot of water. We want to make sure the tendons are still making decorin, which binds a small amount of water. So there's lots of different levels of physiological change under the banner of mechanical capacity, and that can be a little bit tricky to kind of measure. People have tried with elastography and stuff like that. When we're younger, some of our adaptation is just laying down more tendons, much like bone during puberty. But as we get older, the changes relate to the tendon that we already have, so to speak. The actual adaptation in terms of AP diameter after puberty, we don't really know. We don't know whether or not we've got a pathological area and it sort of pushes out the normal tendon you had anyway, or if there's some mechanism for sort of growing like rings around a tree. So tendon adaptation isn't something that is really well understood, but how do we go about it is the key clinical question. If you're looking to improve tendon capacity, you have to remember how closely linked it is to the muscle. So the muscle can only function or the tendon can only function with a really good muscle. So what we're looking to do initially in either rehabilitation or prevention or just athletic function is to make sure our mechanical capacity and our muscle capacity is amazing. And that might have components of endurance depending on the sport. It might have specific strength. It might have power. But if we have a really floppy muscle, your tendon's got nothing to pull on. If I'm going to sprint in the 100 meters, my gastroc is quasi isometric, and it's actually my Achilles tendon that's doing a really amazing job. So I can only do that with a really amazing triceps surae complex. So how do we do that? Strength training. So the Bowen paper showed that strength training, isometric and isotonic, was what improved plyometrics and improved stiffness, not plyometrics. So if you're saying, "Oh, I want to be stiffer and improve my sort of contact time," then get in the gym.
Okay. So that's awesome. That's how we improve what a tendon does
Yes.
from a practical standpoint. Now, if someone has a tendinopathy, not a paratendon pain or a bursa pain, specifically tendinopathy, I think where my mind would have gone to maybe a few years ago is that, okay, well, then we want to treat that tendinopathy exactly how we would treat the tendon if we were trying to get it to perform better. Now, I don't think that's necessarily a bad idea, but would you say that that's the best way to make a tendinopathy less painful? Yeah.
I think I like where you're going with this. So when we talk about the early stage management of tendinopathy, even differential diagnosis, it only matters at the start and at the end. It's actually all about performance. So in the beginning, what I'm looking to do is remove the provocative load and provide safe start loads and education. That's my goal. So if we take a painful Achilles tendon, so in the beginning, I'll say, okay, our provocative load, say for an insertional Achilles, is combination, so compression and tension. So if that person's in dorsiflexion or pushing off from a dorsiflex position, that's where they're most provoked. All right, so how do we remove the provocative load? We might get them to stop their sport for a period of time if that's appropriate. We'll make sure all of their gym work is out of dorsiflexion, including the sneaky compression. So making sure they're not getting into dorsiflexion in a deadlift or any other exercise in the gym. So a nice vertical tibia. I might give them some advice to add a heel to the bottom of their shoe so that they're not getting into compression walking around. But I'm not resting them. Because remember, all I'm doing is removing the provocative load, not all load. So they're in the gym. They're doing isometrics if you want. They're absolutely doing isotonics. I'll also then be looking at the different components of what their calf needs. So they might be doing calf endurance, seated calf, standing calf. And then because I've removed the provocative load and I've applied safe start loads, that's how we're managing the pain component of their tendon. That will settle them down. And then it's all about performance. What does this person want to be able to do? And how do I build them back up through their whole kinetic chain and their calf to be able to do that? So I think that very early stage around pain is having a good understanding of provocative load and safe start loads. And then after that, for me, it's all about return to performance. Whatever that person's performance goal is, even if it's walking around the block, what do they need to be able to do and how do I help them get there?
Got it.
Does that make sense?
There ever? Yeah, no, it does. It totally does. I think one question I had about the training modality when it comes to getting out of pain is I'm curious if training for performance is the superior way to help people recover from pain specifically. I think it's a great idea to build people up to get back to doing whatever they want to do. Like, obviously, right? But can we say that that's the best way to address their pain? Or is isometric exercise better? Or is isotonic exercise better? Or are eccentric contractions better? Or is swimming better?
Understand. Yeah, so I think I think all of those things will have a role. It's maybe how we think about prescribing them. So I often get that question, is isometric better than eccentric, better than isotonic? And what I'd say is they actually all have a role in rehabilitation, but it's about knowing when you're applying it. So the Visnes study in 2005, fantastic study, showed that if you apply eccentric load in season on top of in season loads, people did worse. They had more pain. So it's about understanding when our different rehabilitation options are appropriate. So I would say to you, isometrics can be fantastic, but geez, they're not a complete rehabilitation strategy. They're so far away from performance. So they might be used at longer duration early on for some pain relief. Isotonics are critical because they actually improve, function. But then we can't stop there as well. We need to retrain the spring of the tendon to get back. So I think they all have a role. It's about thinking about how they integrate. So to answer your question around what's the best in terms of performance, it would be understanding the progression and applying that progression appropriately. Energy storage and release, critical for performance, will be disaster at the start of rehab because they have too much of that load. But at the end stage, that's really important. So if I was going to say to you, the evidence that we have for reducing pain is remove the provocative load, apply isometrics and isotonics, because by definition of a tendon, they're not fast. So anything slow or static is not provocative. So that would be good early stage, but not complete rehab.
Got it. Yeah. You've done some work on in season doing isometrics for pain relief, right?
Yeah, we did a couple of studies.
In the moment. So for a very acute pain relieving effect, is there a best exercise for that? Or isometric? And I guess a big component there is that it would depend on the context, and if the athlete is in season, and if we knew eccentric exercise can maybe make them do worse, then we would take that out of our options. But is
Yes.
isometric usually the go-to there?
Yeah, good question. So we did a couple of studies that looked at the acute effect because I hypothesized that we were just warming the tendon up and that one wouldn't be better than the other. So the way I explored that was that they both had the same time under tension, and one was just holding it and one was moving it, but for the same period of time. And my hypothesis was that they'd be the same. So in that small laboratory study, isometrics had a better immediate effect. We then took that into a 4-week in-season trial to sort of look at it in the real world, and using a leg extension machine, not a Biodex. So a Biodex is like perfectly isometric, like you're not moving it. Whereas the leg extension at the gym, you know how you're sort of holding it up. So it's a different type of isometric. And what we saw is that athletes had a greater immediate effect of isometric, but over 4 weeks, there was no difference. So clinically, you actually have two options for people in season for safe management of tendons. So I think isotonics are really important, and I think isometrics can be a really nice add-on. If I've got someone who's very sore, I'm very happy to try an isometric. It can be really empowering for people to have a non-medication based way to manage their own pain. So it can be great for buying. It can be great for the person that's a bit scared of exercise as well, or a bit fearful of the pain, because it's the least challenging or dangerous exercise to do, you know, compared to what they might have done. So it can be a nice way in, but don't stay there. Make sure you move people on and get them on the isotonics, and then, you know, some progressive spring type exercise, like, you know, walking upstairs, going upstairs a bit quicker, bounding upstairs, all of those things to actually retrain that spring.
Right. Yeah, I think in my mind, when I thought about that acute, really short-term effect, I'm thinking of maybe the basketball player who has a painful patella tendon and he has to play in a game or has decided to play in a game. And maybe like those isometrics can be a tool that he could use prior to the game to help with his performance. But
That's exactly
that
how
wouldn't
we
be a
use
good
it.
like okay, cool.
Yeah, so that's a great in-season strategy. So isometrics are more of a management strategy when they're longer duration. There's different reasons why you might use a short duration isometric as more a performance kind of, you know, the strength and conditioning crew do a lot of that. But, you know, isometrics can be a great management tool in season. And yeah, they're a safe tool for people to use as part of their overall kind of management.
Hey physios, I know that we all know how expensive continuing education courses can be. What if you had the chance to learn from some of the brightest minds in the industry from the comfort of your own home, all at the fraction of the cost of those weekend courses? This is where Masterclass by Physio Network comes in. Imagine having front row access to the world's leading experts breaking down complex topics into digestible module-based video courses. It's basically like Netflix for physios, and it gives you the option to learn about a ton of different topics. If you're interested in a particular area, the chances are that Physio Network already has a masterclass on it, or they're working on one right now. Masterclass is your ticket to staying relevant, informed, and delivering the best care possible to your patients. Click the link in the show notes and use the discount code NOAH10 at checkout to get an exclusive 10% off on Masterclass. Don't miss this opportunity to elevate your expertise. If you're still unsure, test it out with a 7-day free trial. You're going to love it. Very cool. So we've speaking of management, we've talked a lot about removing that initial really provocative load and the thing that's making the pain worse. And we spoke a little bit about the difference between tendinopathy and paratendon there and how the provocating factors are different. Do you ever not remove these provocative loads? Are there any contexts where you just decide to build someone back up instead of sort of trying to calm the tissue down? And does that differ between the paratendon, the bursa, and the tendon?
Well, there's 17 questions in there, so let
I
me
know, I'm so
tease
sorry.
that apart. No, that's okay. So your first question relates to, are we talking about in-season management or rehabilitation? So if we're talking about in-season management, someone is playing and training. What we're trying to do is keep their pain low and stable, but they're actually still completing their provocative load because that's their sport. So we're not taking away all their provocative load. What we might try and do is bring it down a little bit. So if for our insertional Achilles example, we might try and remove the compression from their gym. And sometimes that just brings the load down enough to settle their symptoms, usually not to zero. So it's also about expectation management of all of the stakeholders. So what are we trying to do? We're trying to keep this person playing and training. Is the athlete happy that their symptoms will be low and stable, but not necessarily zero? Does everyone on the team understand what is high tendon load? Because if you have the Achilles, what you don't want is they're doing skipping and a warm up in the gym, because that's also high tendon load. So it's going through and making sure that everyone is using shared language and they're on the same page. So if we have an example of in-season management, it's a great example of when we're not always just removing load and calming the tissue down. That's trying to negotiate on what we can and keep someone going. That's when your isometrics and isotonics are critical. The worst thing you could do is add more high tendon load. So that's not where you add energy storage and release, additional plyometrics, all of those things. The different situation is rehabilitation, where it's either the off season or someone's made the decision to stop playing and you've got the opportunity to remove all that provocative load and build someone back up. So you're right, they're two scenarios that we really frequently deal with. If we go to the second part of your question around the peritendon, they're pesky little things. They don't get better unless you remove the provocative load. So even in season, they're really tricky. So what I might do with someone with a peritendon condition is definitely get them to go to a bootmaker and add a heel underneath their shoe. Sticking the little wedges inside their shoe doesn't get them up high enough. But if you get them in a decent heel of a few centimetres, they don't go through as much range of motion walking around. The other loading strategy that I love is getting them on stairs. If you get someone walking up and down stairs, it's quasi-isometric, but it's not a long time under tension. A sustained isometric bunches up the peritendon and they're worse. So that's another little clinical tip.
Oh.
If you've got someone with peritendinitis that says to you, I hate isometrics or I hate isotonics, it's not a tendinopathy. It's a peritendon. They can have crepitus on a stethoscope, so you can hear the crepitus. Depending on your relationship or your availability with like medical management, there are some medical interventions that we can use as well. But removing the provocative load, so removing movement, getting them off the bike, getting them off, anything through range, even getting them off calf raises, but putting them on the stair program.
Wow. How long would you typically do that for? Take off it definitely depends, right? But is there a general timeline that you would tell people when you're taking away all these loads? How long you're doing that
Yeah,
for?
it definitely depends. And the longer they've had it, the harder they are to settle. So the ones that I've seen that have been picked up really quickly, sometimes we can settle them down in a week. But I've seen ones that they've had it for months because it's been missed. They've been managed as a tendinopathy. They've kept doing calf rises. They've kept doing loading because load's good for tendons, and they just get worse and worse and worse and worse and worse. And so they can be persistent. And so some of the topical creams that we might use through the doctor, we might need to do that a couple of times, but it's not a magic bullet. We still need to remove that provocative load. And so they're really tricky to manage in season because if they're still running around, you're not able to remove the provocative load. So sometimes they might choose to rest that player for a week or two so we can settle it down and then build them back in. Remembering that because their provocative load is movement, when we build them back in, we actually build them back in through small range calf raises before we get to a through range calf raise. But we do have to get there because underlying poor calf capacity is the reason they got their peritendon in the first place. So you can't just have a week off and go back to training because you haven't addressed the underlying deficit.
Right. So it's important to build them back up after you take
It
away
is.
all of these loads.
It is. And I'd build them back up through small range first, but quite heavy, going back into full range, and always starting with seated calf raises, a nice, like, easier way to kind of get people back in.
Why is that compared to standing?
Um, I think if you, I think you just don't put as much load through because you don't have, plantaris and gastroc as much mechanical advantage.
Hmm.
Yeah, I'm not sure actually. Might need to think
Hmm.
about that.
Okay. Keep me posted.
Sometimes we play around with these things clinically, and then I get asked a question like that, and I haven't actually thought it through. So it's good because I need to think it through. Someone will be listening and they'll have an answer and they'll go, "Why didn't of course it's this," but I haven't thought about it yet.
Yeah. Yeah, yeah. And I feel like there's just so many things that we see that tend to quote unquote like work in the clinic that seem to do well, and then we sort of stick to those things. And
We have
my
to check ourselves with that sometimes, though.
yeah, yeah, it just seems like that's why work is in quotations, because how do we know that there's not natural history? How do we know that something is going on behind the scenes that we're not thinking about? Like, there's so many reasons why people get better, and I'm really confused as to why people get better when it comes to tendon pain. So as I mentioned earlier, there's the systematic review that said that there's not good evidence to say that people are getting better out of tendon pain because their like performance, like their function and the structure doesn't necessarily need to change in order for people to get out of pain. And I'm going to pose a very strange question here. And this is me purely playing devil's advocate. Okay. So I just want you and everyone to know it here that I don't necessarily think this way. But
I'm
if
ready.
that's the case, why train the tendon? I think classical or the muscle or calf raises or any of the things that attack or aim to cause the local structures to necessarily change. And I think that's typically what we think of, right? Like, people are in pain because there's some sort of damage there, or because like this area is weak, so we got to build it up. But if we don't know that's the case, why do we do it?
I think ultimately what we're trying to do is take someone from their current kind of capacity to what their functional goal is. And I think the problem with or not the problem, the challenge with a systematic review is just the detail of all the people that are in those studies. But you're right, people get better or don't get better for so many different reasons. So my brother used to say that I just distracted people until they got better. Like, I just kind of entertained them. And I think, I definitely feel that there's been times where I've just kind of, supported someone while they've gotten better. But in terms of, tendinopathy, what I love is we actually can measure things along the way around people's function and see an improvement. So why do we train the tendon? Why do we train the muscle? Because if you want to run a marathon, I could be the nicest person and have the best therapeutic relationship with you in the world. But if you can do 6 calf raises, I haven't done my job.
Right.
So I think we have to remember that we have. You're right that there's so many things that feed in. So we do need. We need that person to have confidence in us. We need to build their self-efficacy. They need to understand, what's wrong, how long will it take, what can I do, what can you do? So our 4 questions of self-efficacy. But I think we also need to make sure we're trying to address what we think are the components for them to be able to return to function. But in that systematic review, you might have had people that wanted to walk around the block and people that wanted to run a marathon. And so,
Mm.
how have people improved, and how are we defining improvement? And, one of the first studies we did as a randomized controlled trial in season, we also asked people what their like whether or not they thought they got better. So we did a global rating of change scale, and we had one of the athletes he'd started with the season with 7 out of 10 patella tendon pain. I think by the end of the season, he had 2 out of 10. He didn't miss a game, played finals, and he scored himself as not improved. And so I said, I'm so interested in that actually. And he goes, I've still got pain. So his definition of success was 0 out of 10 pain. So for some people, their definition of success is, being able to keep playing and training. But for some people, it's 0 pain. And that all relates to expectation management. So what I took from that, so I said right at the start, being a researcher makes me a better physio, and being a physio makes me a better researcher. What I took from that was expectation management. So his expectation was that 0 out of 10 pain was a good result, and anything else, he wasn't better. And so now I'm really cognizant when I'm speaking with athletes and coaches and parents and all the stakeholders. If we're talking about in-season management, you may not be 0. What we're looking to do is have you play and train as much as possible and perform as best you can, but you may not have 0 pain. Is that okay? Mm-hmm. And really, seek their input around what they're prepared to put up with. So I learned a lot from that. So, going back to the systematic review, how people define being better is different. It might be different for all of us, even at different, parts of our life. So, yes.
Yeah.
It's tricky to capture the complexity and the messiness of humans in research, but it's fun.
Totally. And when I ask myself that question, why do we do these exercises? In my mind, that's one of the things I always come back to. Like, there's a big difference between pain and function, and certainly someone's expectations play a role there. And your story there just reminded me of someone that I'm working with he's a volleyball player, a young volleyball player with patella tendon pain. And he got to the point where he was in tons of pain during and after his game. And now he still has some, but it's greatly diminished. And he feels like he could play a game to the full capacity. And he's only in minor pain afterwards. And I asked him, where are you at with all of this? First off, do you feel like you need to keep coming to physio because it seems like your management is really, really good? And he said something along the lines of, even if I have this pain for the rest of my life, I feel like I'm completely okay with it. And I feel like as physios, we can get so wrapped up in addressing people's pain and trying to make it go away all the time that we don't take a step back and just, ask the person, how are they coping and how are they managing things? And are they okay just getting on?
I think you have made such an important point around really understanding what that person's goal is, because often it is being able to do what they enjoy, and that some level of symptoms they might be prepared to accept or not. And you're so right. It's not up for us to decide. And we can be so focused on the pain or so focused on the calf or whatever it is that we actually don't take that step back. So I think that's a really fantastic point.
Yeah. And I think it's something a lot of physios probably struggle with, that people come and see us, and in our mind, it's like, oh, they're coming to me for a painful problem. I need to make the pain go away. But a lot of the time, the pain is limiting someone from doing something that they really value. So is it always the pain, or is it the valued activity?
And a good example of that is if you have someone that runs and, maybe runs for their mental health. And the question I often get is, should they stop running? Well, there's so many factors actually that will help you make that shared decision. I never tell anyone to stop. That they're a human. That's their choice. But what I want to do is help them, is there a way that we can manage their running load over a week? Can we get them to run flat and not on hills if it's their insertional Achilles or, a proximal hamstring? What can we modify that just brings their load just under their capacity to something that's tolerable if their priority is maintaining their running? So, yeah, it's really true. And I think at uni, we're taught like our list of questions and, to get a pain score and get a provocative activity and get something we can reassess. And I think all of that stuff is important, but we just shouldn't forget what is their goal. Like, why have you come to see me? And it's not always because X hurts so much, particularly actually when it comes to tendinopathy, because they warm up. It's usually that it's taking away what someone's good at or what they want to be able to do, as opposed to pain severity. It can be pain severity, but it's often that it's impacting function and life.
Mm-hmm. Something that you mentioned there was that you don't always take people out of their activity entirely. And I'm such a sucker for that sometimes. I really don't like taking people away from the thing that they love to do unless I feel like they absolutely have to. I spoke with a young clinician named Bo recently who specializes in stress fractures. And we were talking about how you sort of just need to shut it down sometimes when it comes to that. But in most contexts, I try not to. So we also discussed when it comes to a paratendon, the more you do something, sort of the worse it can get. When it comes to someone's paratendon pain, can you sort of just reduce their running loads to the point where they don't get any pain, and then that's where you cap their run? And is that enough to help them sort of calm down the issue? Or do you really have to shut it down, more similar to, a bone stress injury?
Yeah, it's a great question. So, if you get them really early and they're not too dysfunctional, then yes, because if we consider that peritendon becomes overloaded at the point at which their calf fatigues, is there a period of time where they can run with good technique, terrible term, but you know what I mean, before they start overloading their peritendon?
Yeah.
Then yes. As they continue to decline and get more dysfunctional, then your window gets smaller. But if you get them early and they're not too bad, then yeah, you can.
Okay, great. That's always good news. Good.
Absolutely.
Yeah.
So it really is, so what you might do with that is you might say, how far into your run do you get it? And if they go, within the first 100 meters, you might be in trouble.
Yeah.
But if they're not getting it till 5 kilometers in, you might have a little bit of play there.
Right. You're not going to tell someone, okay, it's happening at 100, try 50. That's not really the best suggestion.
Probably not a lot of point. Yeah,
Yeah.
absolutely.
Yeah, they're going to look at you like you have two heads, I think.
Agree.
Yeah. Okay, I think that is a pretty good point to wrap things up. Sort of this idea that, our patients are more than just their painful problem, and they're human beings, and that we don't always need to shut things down entirely. And ultimately the goal is to connect with the person and help them with their goal. And that may not always be just to get out of pain. But before we do wrap up, Ebonie, is there any parting messages that you want to give to someone? Maybe if you can go back 20 years and talk to the old Ebonie and how you would typically approach a person with a painful tendon. Is there anything that you would try and say to your former self? Or just as a physio?
Yeah. Stop talking and listen was what I was going to say. Because there's great research that shows that physios interrupt within about the first 8 seconds or something. And I still stop myself because we're so keen on making sure we get all the information and we get through our questions. So I just let people start talking and I start making notes. And if I've got something that I want to interrupt and I stop myself and I make a note of it to come back to when there's a good opportunity. So I want everyone on the call to just think about their next subjective assessment and think about how far in before they interrupted their patient or their athlete, because I think it's a really interesting reflection. The other piece of advice that I love to give young physios is physiotherapy is so much fun. And there are so many amazing opportunities that if you don't love your job, consider changing your job, not your profession, because there's lots of different types of physio. There's lots of different, opportunities, as I said. And I speak to a lot of young physios in private practice, seeing, a squillion people a week getting burnt out and not feeling passionate. And I think that's a shame. So I think we should all work together to support each other. And, it can take a lot of mental and physical energy to be a physio. So just look after yourself, because you do give a lot of yourself.
Amazing. Couldn't have said it better myself.
I tell you what, good luck editing this with all of the different interruptions we had between the dog and the doorbell, and oh my goodness.
Yeah.
But I really enjoyed our chat.
Me too. I really did. It was memorable for sure. And I hope that, I hope that it's able to come through pretty well, but I think it'll be all right. But I really, really appreciate you coming on. I mean, anytime I read a paper of yours or I listen to a clip of you, I always learn a ton. So it was just really a pleasure to be able to do it while actually speaking to you this time.
Thank you for having me. And honestly, if you listen back and it's a complete dog's breakfast, we'll do it again.
Okay. Well, I mean, regardless if it is a dog's breakfast or not, I would like to have you again if you're up to it.
Yeah, great.
Cool. All right, Ebonie. Well,
I'd love to. Thank you.
My pleasure. Nice to meet you.
Nice to meet you.
Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.